Welcome to this presentation from Wessex Patient Safety Collaborative about RESTORE2mini, the physical deterioration and escalation tool for the care sector. This presentation is intended to provide information about RESTORE2mini for carers, trainers and managers to help with the adoption of the tool in non-acute care settings. This presentation and associated slide deck may be adapted for local use, providing the copyright requirements of all materials, including RESTORE2, RESTORE2mini and News2, is respected and appropriate acknowledgement given to West Hampshire CCG and Wessex Patient Safety Collaborative. RESTORE2mini is a patient safety initiative co-produced by West Hampshire CCG, now part of Hampshire, Southampton and the Isle of Wight CCG, and Wessex Patient Safety Collaborative. This presentation and the slide deck on which it's based is taken from the RESTORE2 Rollout Handbook. You don't need the handbook to listen to this presentation, but you might find it helpful to have a copy available in your organisation for later reference. RESTORE2 was originally developed for use in care homes. However, RESTORE2 and RESTORE2mini are now used in a multitude of settings, not all of whom use the term residence and care homes. This resource, though, is based on the original Rollout Handbook and hence tends to use the terms resident and client throughout. Other terms used include carers, which was used to refer to any member of staff in a residential or care home setting engaged in caring for a client or resident. DNA CPR refers to Do Not Attempt Cardiopulmonary Resuscitation documents. News stands for the National Early Warning Score, currently News 2. The term residential and nursing is taken to refer to all the different types of homes that provide care to clients or residents, including domiciliary care settings. TEPs refer to treatment escalation plans, which are personalised recommendations for someone's medical care. A TEP may be informed by an advanced care document or an advanced decision to refuse treatment. These will be covered in your own organisation as appropriate. Vital signs. The training materials refers to vital signs and observations, but RESTORE2mini won't be covering the taking of observations and the use of the News score. Deterioration, including sepsis, is often recognised late, sometimes too late, and can have life-changing consequences. But what if we could identify it sooner? In hospital, in the emergency department, in the ambulance, at the GPs, or in the care homes? And what if we all spoke the same language and could communicate our concerns better, using methodologies like Soft Signs, News2 and SBARD? So before we look into RESTORE2mini, let's just take a quick look at RESTORE2. As we move through this training presentation, we'll be referring to the relevant sections in the Rollout Handbook, in this case page 6. As I said, it's not essential you have the Rollout Handbook handy, but if you do, you can refer to it as you go. We'll also be referring to some videos that we've recorded that are available through Health Education England, and I'll be talking more about those later. There are 3 particularly relevant to this section: Introduction to Sepsis and Serious Illness, number 1, number 2, Preventing the Spread of Infection. And whilst we're not going to be covering News 2 in RESTORE2mini, it's useful, it's relevant to RESTORE2, and it might be something you would be interested to look at later. RESTORE2 is based on getting the best outcome for residents or clients. If any one of us was unwell, we would want the following things to be in place to give us the best chance of a good outcome. We'd want someone to recognise our deterioration early. We'd want healthcare services to get to us as quickly as is required. And we'd want a clinical response that meets our need. These 3 things are called the triad of clinical outcomes. So how does RESTORE2 work? There are 5 elements that support carers to recognise deterioration, assess the risk, and act on your findings. Starting with the early recognition of soft signs. The value of soft signs is they help you spot subtle changes in behaviour. So we need to know what's normal for the individual we're caring for. And that needs to take into account any end of life or agreed limit of treatment care plans that they might have in place. With RESTORE2, we move on to taking observations, calculating a News score, and raising concerns using SBARD escalation tool. And this is what Restore2 full looks like. 6 sides of A4. We've got soft signs and what's normal for the resident or client on the first couple of pages. Then there's the observation chart for the news score. And then there's the SBARD escalation tool and action tracker. Restore2mini, however, takes a simpler approach based on soft signs. This is what Restore2mini looks like. It's 2 sides of A5, although there is an A4 version available. It looks at soft signs on the one side of the card, and it looks at the SBARD communication process on the other side of the card. So going back to Restore2, there are these 5 elements of the full Restore2. Restore2mini uses the 3 of those 5. So it starts with soft signs, that recognition of early changes that might indicate deterioration, and then comparing those soft signs to what's known as to be normal for the individual you're caring for, taking into account any end-of-life care plans or agreed limits of treatment documents that might be in place. Restore2mini doesn't include taking observations and using the news score, so it moves straight round to raising concerns based on the soft signs identified using the SBARD escalation tool and action tracker. Soft signs are covered in the handbook on page 11, and 2 specific videos, number 3, soft signs of deterioration, and number 14, recognising deterioration in people with a learning disability. The first side of the Restore2mini tool covers soft signs. As the question, ask your resident, how are you today? And then includes some of the key soft signs of deterioration, although there's many others you might want to consider as we'll look at later. It also talks about recognising normal for the person you're caring for. Early signs of physical unwellness can be recognised intuitively by carers. We hear staff saying, I know something is wrong, I just don't know what. And even people without training, but who are familiar with someone's usual behaviour and habits, can often sense a problem, resulting in them reporting that the relative, resident or child in their care just isn't themselves. And there is some evidence to suggest that it's possible to identify physical deterioration before hard physiological signs are present, with one study finding that nursing assistants could document signs of soft signs of illness before charting signs by an average of 5 days. We've written a paper on this and it can be downloaded from the Patient Safety Collaborative website if you're interested in exploring this further. One healthcare organisation identified over 120 different soft signs and categorised them in a number of groupings. As a carer, you spend time with the people you're caring for, and you can get to know them very well. Sometimes it can be obvious that someone is unwell. Other times the signs might be much harder to spot. Soft signs are the early indicators that someone might be becoming unwell. You don't have to be a healthcare professional to recognise these signs, and as a carer you're ideally placed to recognise small changes in your resident. Often family and friends will pick up on the subtle changes in a person's behaviour, manner or appearance, which makes sense because they're going to potentially know the person you're caring for even better than you do. So family concerns should always be taken seriously, even if you think the resident or client is fine. Soft signs can be related to many things, including the resident's physical presentation, mental state or behaviour and ability. So examples of changes in a person's physical presentation could include being short of breath, not passing much urine, being hot, cold or clammy to touch, or being unsteady when walking. Examples of changes in someone's mental state may include feeling more anxious or agitated, having new or worse confusion, or being more withdrawn than normal. Changes in behaviour may include altered sleep patterns, increased tiredness, reduced inhibitions, or being very restless or hyperactive. Some soft signs are universal, for example new onset shortness of breath or decreased urine output. Others may be unique to that particular person, for example a sudden inability to participate in activities they enjoy, like doing the crossword, a particular change in behaviour such as withdrawal, agitation or hyperactivity. By getting to know your resident or client, speaking with their family, friends and carers, you can build up a picture of soft signs that are significant to each particular resident. We've sorted those out, so given some examples in the handbook and on the screen here about soft signs relating to mental, physical or behavioural or ability categories. But it doesn't really matter which category they fall into. The important thing is you're sensitive to the existence of soft signs, you spot them when they arise, realise they might be indicating deterioration, and you use them to raise your concerns with the senior colleagues or with a doctor. It's good practice to ask the people you care for, how are you feeling today? Allow them time to answer the question in their own way and make a note of individual or unique soft signs in the resident or client's records for future reference. You should encourage friends and family to tell you if they notice any soft signs. And soft signs are particularly useful for people who have difficulty communicating or understanding information due to dementia or learning difficulties. And by learning about soft signs, you may be able to recognise deterioration early and act to protect your residents from serious illness. There are some occasions when the early signs of deterioration may present as a medical emergency. In these cases, it's not appropriate to delay contacting the emergency services in order to collect soft signs or record a news. At this stage, you need to follow your own local organisation's procedures and policies, and of course to continue to monitor your client or resident once you've contacted the emergency services. Situations, for example, include chest pain or a suspected heart attack, when the individual is displaying signs consistent with having a stroke, prolonged seizure, or when the resident has sustained a significant injury, i.e. a fracture or a head injury. It's not appropriate in these situations to delay raising the alarm. Recognition of normal is covered in the handbook on page 15 and on these two videos, number 3, soft signs of deterioration, and 14, recognising deterioration in people with a learning disability. As a carer, you may know your resident better than any other healthcare professional that comes into contact with them. It's really important that when the resident is admitted to your home, you take time to learn about their usual behaviours so that you know if they start doing things that are not normal for them. You understand their medical history, including any medications that they regularly take. You assume that they have the ability or capacity to make decisions about what they want, including when they become unwell. If they don't have the ability or capacity, then the appropriate arrangements need to be made. And that someone has a conversation with the resident's GP about when and in what circumstance the GP might want you to call them with a concern. So just to summarise, as a carer, you're ideally placed to recognise small changes in your resident or client. By getting to know the individual in your care, speaking with the family, friends and carers, you can build up a picture of soft signs that are significant to each particular individual. And if the individual you're caring for has a medical emergency, such as a chest pain, a suspected heart attack or stroke, then follow your local emergency procedures, which may include calling 999. The conversations you have with your client or resident around RESTORE2mini can be helpful in identifying when someone is approaching the end of their life. This can help to inform conversations with them and their relatives or GP. And once someone is receiving care whilst dying, RESTORE2mini and things like physical observations may be withdrawn so as not to cause unnecessary distress. As a carer, you can support people in having conversations about their end-of-life care preferences, and you can help to arrange a treatment escalation plan with their GP. You should understand whether a treatment escalation plan and a resuscitation decision exists and what it says about that person's wishes. And you need to know where those documents are kept so that you can access them in an emergency. A DNA CPR order does not mean that an individual cannot be treated for other conditions from which they may recover. For example, they may still benefit from antibiotics for an infection or first aid for an episode of choking. Treatment escalation plans and resuscitation are referenced in the handbook on page 16 and in video 13. A treatment escalation plan, sometimes known as a TEP, is a personalised recommendation for someone's medical care. It is intended for use in an emergency situation as a reference and communicates the level of care in the resident or client's clinical management. A treatment escalation plan is made with the client or resident and their caring team, and often with their family. It is ideally made when they are well and can say what they would want to happen. If your client or resident does not have the ability or capacity to make decisions around what they want to happen, then a suitably trained person should undertake a capacity assessment. When a resident you're caring for becomes unwell, there are different options to looking after them. Knowing your resident will help you to support them to live well, but also to think about what they would like to happen if they become unwell. If possible and safe, most residents and clients would prefer to be treated in their own home. For some individuals, it would be appropriate to call the GP or 999 to arrange admission into hospital. For other people, going to hospital is not appropriate or in their best interests, and this can be for a number of reasons. Often people who know they are approaching the end of their life may have decided they want to die in their own home and not in hospital if possible. And for others, perhaps where there's been a specific illness or an event has happened, they may have previously expressed a wish to be looked after by people that know them in a way that maintains their dignity. There are helpful documents available that support people to have a say in their care prior to when they become unwell. And these include treatment escalation plans or TEPs and do not attempt cardiopulmonary resuscitation, DNA CPR documents. RESTORE2mini promotes a soft signs based approach and does not include the taking of physical observation or the use of News 2. We've got other training material that covers the full version of RESTORE2 and covers the taking of physical observations and the use of News 2. And some of the videos we talked about also cover that material. So if you're interested, there is more information that can be located. However, RESTORE2mini does not include the taking of physical observation or News 2. So, raising the alert, covered in Handbook on page 39 and video 12, Structured Communication and Escalation. So this is the other side of the RESTORE2mini tool. It covers raising the alert. It mentions recording observations and using the News 2 system because, of course, you might have that available in the care setting that you're working in. And if you have got that information, it's important we pass that on to the healthcare professionals. However, it's not an essential part of RESTORE2mini. The card then covers reporting concerns using SBARD. And this card can even be kept by the phone and used as a prompt card for other conversations with healthcare professionals. When you are raising a concern and raising the alert, you must always follow your own organisation's local reporting procedures. You need to know what those are and to follow them at all times. Being able to communicate effectively is a critical skill for everyone working with residents or clients. There's little point in recognising deterioration if you're unable to communicate your concerns in a way that makes others take action to support you to manage your resident or client. It can be difficult to communicate when you're under pressure or tired. It can be challenging communicating with so many different groups of people, including GPs, the ambulance service and community teams. It's good practice to always try and plan your communications so you know what essential information you need to include. To assist you in getting your message across every time, RESTORE2mini uses a structured communication tool, SBARD. This is easy to use and helps information to be transferred accurately and safely between people. SBARD stands for Situation, Background, Assessment, Recommendation, Decision. And the evidence shows that using SBARD helps with communication, confidence and patient safety. So you can practice using SBARD every time you are handing over information to a colleague or healthcare professional, and soon it becomes more familiar. You can have the SBARD template available next to the phone so that you can use it as a prompt when you need to. Once you've escalated your concerns, you must still continue to attend to the immediate safety and comfort of your resident or client. Carry out and document any of the actions you've been asked to take. So let's look at the components of the SBARD communication tool in more detail. Situation. Introduce yourself and state your role. Explain where you are calling from, who you are, and whether you are a carer or registered nurse, and what your direct phone number is in case you get cut off. Provide key information about the person you're calling about, including their full name, date of birth, and NHS number if known. Explain what it is you're concerned about, and if you do know the news score, then you can pass that on as well. Background. Briefly state the resident's relevant medical history and what has got you to the point of calling for help. This could include medical conditions, any treatments or medicines that they are on, and whether they have an end-of-life care plan or any limitation to treatment. You could include the last GP review if relevant, any new medicines like antibiotics, test results that are awaited, and the resident or client's last set of vital signs if known. Assessment. This is where you can summarise what actions you have taken so far and suggest what you think might be happening. If you aren't sure what's going on, don't let this put you off raising your concerns. You can include signs and symptoms, including diarrhea, skin rash, pain or fatigue, for example, any pain relief or other medications you have given, actions like repositioning the resident or client, other observations like urine output or blood sugar, glucose. Recommendation. Think about what you would like to see happen next. This may include whether you would want your resident or client to be seen by a healthcare professional and how quickly. You can also ask what actions you could carry out, either to manage the individual or whilst you wait for help to arrive. You can use phrases like, please could you, or I need you to, and what do I need to do next, or is there anything I need to do in the meantime? Decision. Finally, summarise your agreed management plan so that you are both clear on what each of you will do to care for the unwell resident or client. Importantly, remember to document this conversation in the care plan. You could use phrases like, we have agreed that you will, and I will do, and if there is no improvement within X, I will take X action. Always know your direct line telephone number so that a call handler or health professional can call you back quickly and easily without having to go through a switchboard, reception or other floor of your home. If possible, use a portable device to make your call. That way, if the ambulance service need to speak or see the client or resident, they don't have to hang up and call back on a different line. It's important to say that you may not be able to follow the SBARD communication tool when speaking to the ambulance call handlers, as they use NHS pathways which takes them through specific questions in a certain order. However, by having planned your conversation, you should have all of the necessary information to hand. Some ambulance services use a different structured communication tool called ATMIST. You should use the communication tool you have been trained on and feel most comfortable with. If your client or resident needs to be omitted, make sure that your RESTORE2mini details are copied for the crew, or ask them to photograph them and upload them to their electronic patient record. RESTORE2mini is your legal document. Don't send the original into hospital if you can help it. If you are using a digital version of RESTORE2mini, print the observations out for the crew to give to the hospital. And just to reinforce this point about not being able to follow the SBARD communication tool when you're speaking to ambulance call holders, this is because they follow their own pathways. They have a certain number of questions and they have to proceed in a certain order based on the information you provide them in order to get the right care to you as quickly as possible. We're going to look at some scenarios now, putting all this into practice, and that's covered in the handbook on page 42, although this presentation has been developed to support the online delivery of training rather than the face-to-face sessions covered in the handbook. So we're using different scenarios here to those in the handbook, but both you might find useful. So starting with soft signs and looking at David, who's a 67-year-old chap who lives in your nursing home, primarily because of his poorly controlled diabetes. He's a double leg amputee and sometimes uses a wheelchair. He often stays in his room. When his blood sugars are high, he gets headaches, becomes increasingly tired and feels very thirsty. He also gets very grumpy. Take a moment to think about how you would view these soft signs. So we've got increased drinking, he's more withdrawn, he's tired and drowsy, he has increased urine output, he's grumpy, and he has headaches. So some of these may be signs of his diabetes, and others might be for other reasons. We can't rely on any one of these, but when we see something like this, and when we compare it to what we know is normal for David, we might think there's something going on here. We can sort them into the categories of physical, mental, behaviour and ability, and some people find that useful. It's not essential though. We've noted here 6 things that are not normal for David, or are normal for him when he's deteriorating. But when he's fine, he doesn't have these issues. So looking at Molly, she's a fun and outgoing 78-year-old. She mobilises with a Zimmer frame and loves to socialise with other residents and staff in the lounge. When she's not talking, she's an avid reader of romantic novels, and you can often find her with her head in a book in the conservatory. Molly often jokes that she's too busy to sleep, goes to bed late and tends to get up early. often having a cup of tea with the night staff before they go off duty. So take a moment to think about how you would view Molly's soft signs. So she's less able to mobilise, more withdrawn, less sociable, less able to concentrate, decreased fluid intake, tired and sleepy, less able to read, and spending more time in bed. So we can't look at any one of those. But if we sort them out, as I say, don't need to do this, but some people find it helpful. We can see there are physical, mental and behavioural changes to Molly. And if we look at just one, she's less able to read. That is significant to Molly because we know she's an avid reader. Someone who doesn't read, that wouldn't be a relevant soft sign. So again, we're not looking at any one individual thing because that could be due to a number of reasons. She could have had some bad news from her family and not wanted to read, for example, that day and wanted to think things through. But when we see a number of these things going on, we might be concerned that there's something going on with Molly. We don't have to know what it is, but we've spotted the fact she's not herself, and that might be a sign that she's not well. And that's perfectly okay to then raise those concerns. So looking at the SBARD process now, looking at Simon, who's an 81-year-old resident. He's been in your home for 2 years. You know him very well. He's always cheerful and engaging, although he has dementia. He has trouble remembering where he is and has to be supported to take his medication. However, he always recognises his daughter when she visits and loves talking about old memories. Simon is physically well and only takes tablets to lower his blood pressure. He's prone to chest infections and has just-in-case antibiotics in the home. Simon has a treatment escalation plan that states he is not for resuscitation, but he is for full medical treatment of any reversible illness. This includes being admitted to hospital for treatment. When you see Simon today, he looks more withdrawn. His daughter tells you that he struggled to recognise her and thought that she was his mother. He sounds chesty, so you sit him up. So let's look at some of the soft signs that we've spotted. He's always very cheerful, engaging. That's normal for him. But today, when you see him, you think he looks more withdrawn. He always recognises his daughter. But today his daughter tells you that he struggled to recognise her and thought that she was his mother. He's prone to chest infections, and today he sounds chesty to you, so that you sit him up. And he has a treatment escalation plan that states he is not for resuscitation. So let's put that into an SBARD communication. There are no correct answers for this, so don't worry if you put some of your comments in the assessment section instead of the background. As long as you include them in a structured communication, that's what counts. As an example, it might sound something like this. My name is whatever, and I'm calling from the residential care home. I am a carer. My direct number is this, and I'm calling about Simon, an 81-year-old resident. I'm concerned that he is chesty, with a higher than normal breathing rate, and more confused and withdrawn than usual. So you've covered the key information, the soft signs that you've spotted, and the fact that they are significant for him. The background. Simon has dementia. He always recognises his daughter, but struggled to recognise her today and thought that she was his mother. Simon has a DNA CPR in place, but is for full treatment of any reversible illness, including hospital admission. He gets recurrent chest infections. He is currently on a blood pressure medication only. He does have antibiotics in the home. He has deteriorated in the last 24 hours. So in very few words, you've got a lot of information over there in a clear and concise way. You move on to your assessment. I think he has a chest infection. And you say what you've done. I have set him up. And it's okay to say, I think, I'm not sure. This is important information, and what you're doing is passing on your concerns. If you're talking to a nurse or a doctor or an ambulance care worker, they will make their own decisions. They will implement their own treatments. But you're passing on your concerns, and it's not for you to diagnose conditions, but if you're concerned, that's fine to say, I think he may have. And then your recommendation. Please could you come and see him in the next hour? Would you like me to start his antibiotics? And the key thing there, you're just reminding the person you're talking to that starting antibiotics is an option that you could do if that's appropriate in your care setting. And the decision that you reach. The GP agreed to visit in the next hour and to review the antibiotics when he visits. And from the perspective of your care organisation, you've agreed to continue to monitor, encourage fluids and keep Simon comfortable and upright until the GP visits. So let's now look at Charlie, who's a 67-year-old gentleman who moved to his supported living flat 3 months ago. Charlie is generally fit and well, has full capacity but reduced mobility. He is on medication for hypertension only and has not required medication review since moving to his flat. One morning you notice that Charlie is reluctant to eat his breakfast and feels he needs to go back to bed for a rest. When you check on Charlie an hour later, you feel his hands are colder than normal and he is beginning to shiver. Charlie has also informed you he does not feel very well. Take a moment to think about how you would use the SBARD framework to communicate your concerns about Charlie to the GP. So you've noticed that today, unusually for him, he's reluctant to eat his breakfast and he feels he needs to go back to bed for a rest. And when you checked on him, the key points are you feel his hands are colder than normal and he's beginning to shiver and he doesn't feel very well. Again, there are no correct answers for this, so don't worry if you've put some information in the assessment when I've put it in the background and vice versa. But just as an example, it might sound something like this. My name is X and I am ringing because I'm worried about a person I am a carer for. My number is this. We have been supporting Charlie for the past 3 months and he is generally fit and well. I became concerned as he is off his food, unusually lethargic, cold and shivering, and is complaining of feeling unwell. So in just a few words, you've covered the being off his food, unusually lethargic, cold, shivering, and complaining of feeling unwell. So a lot of information in very few words. Charlie is 67 years old and alert with full capacity. He is on medication for hypertension, but no other medication. He has not required medical review since we met him. Assessment. I'm not sure what the problem is, but Charlie's condition is deteriorating. And as we've said, it's okay to say that you're not sure. You're not diagnosing, you're passing on your concerns and you're reporting that, in your opinion, Charlie is deteriorating. Please could you visit to review Charlie? Is there anything I can do whilst I'm waiting for you? And the decision reached was that the GP agreed to visit in the next 2 hours after surgery, i.e. between 4 and 6, which is useful information because there's no need to chase the GP before 4 o'clock because you know he's coming between 4 and 6, unless of course Charlie becomes worse. You also know he's going to come by 6 o'clock, so if it gets to 7 o'clock, you think you're able to call the GP again because that's not what was agreed. And we will continue to monitor and call the GP again if Charlie's condition changes before the GP arrives. It's very clear what the plan is for all concerned. Additional resources and recommendations. To support RESTORE2 and RESTORE2mini, we collaborated with Health Education England to produce a series of short, free videos and e-learning materials to support staff working in care homes to care for people who are at risk of deterioration. There are 14 deterioration videos, all around 3 minutes, and we've referred to them throughout this training presentation so you know which ones are relevant to which section. There are also several on the taking of the news score, and they might be of interest to you as well. An additional 7 videos have been filmed specifically to support carers of people with a learning disability. And all these videos can be accessed on the Health Education England website, either through the e-learning for health portal if you have an e-learning health account, or on the Health Education YouTube channel. We've linked the videos throughout the training presentation, but we've also, if you want to look at specific areas such as spotting serious illness, soft signs, taking observations, or escalating and communicating, listed the videos there for future reference. We're continually developing more resources for care homes and care settings, and these can be obtained through the Wessex Patient Safety Collaborative's website. And there's some links here. And later on, if you want to come back to this training video, you can always rewind to this page, pause it here, and write down some of these links and follow them to the relevant pages. So we have resources for Restore2 as well as Restore2mini. Specific resources for domiciliary care settings, learning disability, and so on and so forth. There's the paper you can find on soft signs and other information about deterioration and safety communications. Restore2 and Restore2mini have been recommended by a number of healthcare organisations, including the British Geriatric Society, the Learning Disability Mortality Review Leader Programme, the admission and care of residents in a care home during COVID-19 guidance produced by the CQC, DHSC, NHSE and PHE. Restore2 and Restore2mini have been implemented in care homes across most of England, and the videos have been viewed over 400,000 times at the time of recording of this presentation. Restore2 has also won a number of awards from organisations such as the Peter Carr Partnership Award and the Health Service Journal. Versions and acknowledgements. There are currently 3 different versions of Restore2mini, with more in planning, including the original version for care homes, top left. Top right, there's a version for the domiciliary care settings, which refers to home and clients rather than care homes and residents. And at the bottom of the version for learning disabilities, which refers to the person you support. And as you can see, the bulk of the card is identical. The soft signs are the same and the SBARD is the same. The only things that have been changed on the card is the term used for the person being cared for and the term used for the organisation in which those people are living. So Restore2mini is available in A4 and A5 versions, and it's also available with fields for the patient or resident ID. The following are thanked for their contributions to the development of Restore2. That completes our presentation about Restore2mini, the physical deterioration and escalation tool for the care sector. If you want to go back to any part of the video to spend more time on any particular point, or to take note of the link shown on the screen, then you can rewind to the point of interest and even pause the video while you do so. Please feel free to contact us at Wessex Patient Safety Collaborative if you have any questions or would like to be put in touch with your local Patient Safety Collaborative. Thank you for listening. We hope you found it useful.